Ladies and gentlemen, thank you for the kind invitation. It's an honor for me to stand in front of you and talk about pediatric pancreatitis. First, I would like to introduce you the pediatric section of the Hungarian Pancreatic Study Group, which I'm part of as well. Our pediatric section was established in 2013, and we started the registries for patients who has pancreatic disorders in the same year as well. And we've started our clinical trials, the apple and pineapple trials about pediatric pancreatitis in 2014. And at the same year, we held a consensus meeting in Hungary, and we performed the basic guidelines for pediatric diseases. And our new project is to do genetic testing for patients who has pancreatic diseases and to give them genetic counseling as well. In 2014, we aim to establish evidence-based guidelines for the management of pancreatic diseases, and our fundamental aim is to improve the therapy for patients with pancreatic diseases. The Hungarian investigators translated all of the available guidelines in pancreatic diseases, including acute, chronic, autoimmune and pediatric pancreatitis, and pancreatic cancer. And where they found it necessary, they extended and modified them, and then they compiled the EBM guideline. After that, we consulted with specialists who reviewed the questions and the answers, and they added their own propositions, which were included in the guideline. And then the guidelines were uploaded to our website in order to give free access for everyone to participate. The consensus meeting that I already mentioned was held in Hungary in 2014 during the event of Pancreas Update 2014. And the attendees has heard the questions and the answers that I already mentioned, and they were voting via a secret ballot. And the event was recorded for documentation purposes, and it is available on our website. The classification of the evidence was based on the GRADE working group, which is internationally accepted and was established in 2011. And it was applied according to the up-to-date system guideline as well. We used strong and weak as quality of the recommendation, and we used high, moderate, low, very low, and minimal as quality of the evidence. A 2-degree system was used in order to establish the strength of the consensus. We said it is a full agreement if more than 95% of the voters had said yes, and it was a strong agreement if it was at least 70%, and weak agreement if it was 50% plus one note. So we have made the Hungarian guidelines for acute, chronic, and autoimmune pancreatitis, pancreatic cancer, and pediatric pancreatitis. We posted the slides, articles, and videos on our website, and it was published in the Hungarian journal Orvosi Heti Lap as well. And we are happy to say that an evidence-based guideline for pediatric pancreatitis will be available soon in English on our website. And during the pediatric section, we talked about two major parts, the acute and chronic pediatric pancreatitis. We reached the following topics: the diagnosis, the etiology, the prognostic factors, the imaging, the therapy, the treatment of the biliary tract, and the complications of the disease. Now I only would like to talk about the diagnosis and the etiology. And we've experienced during the consensus meeting that we had a lot of low evidences, and it is because the supplement of pediatric pancreatitis is mainly based on adult guidelines, on adult evidences. So we know it's a weak point, but we need more research, and we need more multicentric prospective clinical trials. And we are happy to say that we started our clinical trials, the pineapple and apple studies already, which I will present tomorrow. And now let's see the diagnosis of the disease. The first question was, what are the requirements for the diagnosis of acute pancreatitis? And the answer, a diagnosis of acute pancreatitis is achieved by meeting at least two of the following three elements: abdominal pain, serum lipase or serum amylase level at least 3 times greater than the upper limit of normal, characteristic findings of acute pancreatitis with imaging methods. And it has got a strong recommendation with moderate evidence. The second question was, what are the characteristics of abdominal pain which suggest acute pancreatitis in children? And the answer was diffuse, epigastric, persistent, or minimally easing abdominal pain suggests acute pancreatitis. And it has got a strong recommendation with low evidence. And now I would like to refer to my previous statement that we need more research on this field, and we target these kind of questions in our pineapple study. But other clinical symptoms could suggest acute pancreatitis. That was the third question. And for the answer, in children, especially in infants and in toddlers, vomiting, irritability, and abdominal distension may suggest acute pancreatitis. And it has got a strong recommendation with moderate evidence. And the last question in this topic was, what laboratory test should be obtained in abdominal pain? And serum amylase and/or serum lipase are recommended to be tested beside the routine parameters, and it has got a strong recommendation with low evidence. And now let's see the etiology. The first question was, what etiological factors should be considered, and in what order should they be investigated in case of pediatric acute pancreatitis? The leading etiological factors that should be investigated after the diagnosis is reached are the following: biliary abnormalities, medication-induced, idiopathic, systemic disease, traumatic injury, infection, metabolic disorders, hereditary pancreatitis, and autoimmune pancreatitis. And it has got a strong recommendation with low evidence. And I would like to highlight the hereditary pancreatitis, which can only be diagnosed via genetic testing. That's why it's important to know the answer for the following question: what kind of genetic testing is recommended in case of pediatric idiopathic pancreatitis and chronic pancreatitis? In case of second episode of idiopathic acute pancreatitis or first episode of idiopathic acute pancreatitis with a family history of acute or chronic pancreatitis or idiopathic chronic pancreatitis, the full sequence analysis of the PRSS1 genes second and third exon is recommended to know the risk for adenocarcinoma. And it has got a strong recommendation with strong evidence. And full sequence analysis of the PRSS1, CPA1, SPINK1, CTRC, and CFTR genes exons and exon interim borders is recommended in order to explore the etiological background as well. And it has got a strong recommendation with moderate evidence. And if these total sequences are not possible, then at least the following genes should be tested: the PRSS1, CPA1, SPINK1, CTRC, and CFTR genes. And it has got a strong recommendation with moderate evidence. And in the content of pancreatitis, why these particular genes are in the focus? To understand that, I would like to present you the pathomechanism of pancreatitis. The trypsin is a key figure in the digestive system. Its zymogen form is trypsinogen, which is synthesized in the pancreas, and serine protease will activate the trypsin. And then the activated trypsin will activate the other zymogens in the body. That's why it's a key figure in the digestive system. But the body tries to stay in a balance, so that's why there should be some ways to stop this mechanism. For example, it is possible with the SPINK1 protein, which can inhibit the trypsin, or with the CTRC protein, which will degrade the trypsin. There are multiple ways which can lead to pancreatitis. For example, in hereditary pancreatitis, the gain of function of PRSS1 gene will increase the autoactivation of the trypsin in the pancreas, which will lead to increased trypsin level, and it will cause pancreas damage. And in case of SPINK1 mutation, the inhibitory factor SPINK1 will be inhibited. That's why the trypsin cannot disappear from the pancreas, and it will cause pancreas damage. And in case of CTRC mutation, the degradation of the trypsin won't happen, so that's why it cannot disappear again, and it will stay in the pancreas and cause pancreas damage. So we can see that intrapancreatic trypsin activity plays a central role in the developing of pancreatitis, as we heard earlier during the presentation of Professor Mössner. So I wouldn't like to go into such details about the genes. I would like to highlight the important cases that are important for a pediatrician. The PRSS1 gene's mutation is a gain-of-function mutation which can cause the hereditary pancreatitis, and it's a dominant inheritance, and the penetrance of the mutation is 80%. The SPINK1 mutation is a loss-of-function mutation which only a risk factor for the disease, and it means a 10 to 15 times higher risk. And the mutation of the CTRC gene region is a loss-of-function mutation as well, and it will mean a 3 to 10 times higher risk. The carboxypeptidase A1 is linked to pancreatitis as well, but on a different way. The protein is the second largest component in the pancreatic juice, and the details why it will cause pancreatitis is not fully known, but maybe it is because the folding of the proteins won't happen in the endoplasmatic reticulum, and it will cause endoplasmatic stress. It is important for pediatricians because the loss of function of this gene region is associated with non-alcoholic chronic pancreatitis with early age onset. And there is another gene which is worth to talk about, and this is the CFTR gene. Normally, it will code an anion channel on acinar cells, which will transport chloride and bicarbonate to the pancreatic tubes, and it will result in a bicarbonate-rich fluid that can flush out the zymogenes from the pancreas. The loss of function mutation of this gene region will cause the disease cystic fibrosis. I wouldn't like to go into details, but because we don't know everything about the pathomechanism between the CFTR gene mutations and pancreatitis, but I would like to highlight that a lot of variants of this mutation is already known, and we know that the disease depends on the location of the mutation. And I would like to highlight the delta F508 mutation, which is really common in Hungary, and it will cause a severe cystic fibrosis, and it will mean a really high risk for pancreatitis as well. So we've discussed the diagnosis, the genetic risk factors, and why is it important to test them. A genetic test should test the gene mutations which directly cause the disease or which are risk factors for chronic pancreatitis. And they have to give relevant information on the disease, and they have to be technically easy to perform. And nonetheless, they have to be cost-effective as well. And we can offer an unbeatable cost-effective way with the Apple study that I will present tomorrow, because we will do all the mentioned genetic tests for free. And why is it important to test and understand the genetic background of a child suffering from pancreatitis? If we see the etiology of the disease in adults, we can see that it's mostly associated with alcohol or biliary problems, and only 10% of them is idiopathic. And the role of genetic factors in this group is under 10%. Compared to this, in children, the idiopathic disease is around 35 to 55%, and in this group, the genetic risk factors' role are more than 30%. So the possibility of having a genetic background in childhood is around 10 times higher. But which age group should be tested? The pancreatitis is a multifactorial disease. Both the environmental and genetic factors are playing a central role for developing the disease. But if we are getting older, the importance of environmental will increase and the importance of genetic factors will decrease. So we think that until young adulthood, it is necessary to perform the genetic tests. And I would like to highlight again the PRSS1 mutation, which is a causative factor for hereditary pancreatitis. And it is well known that if someone carries this mutation, their risk for having pancreatic cancer by the time he's 75 years old is 50%. So in conclusion, we can say that multicentric prospective clinical trials are crucially needed, and genetic testing should be performed for all children who have pancreatitis. And I would like to say thank you for all of my colleagues and hospitals, institutions and grants who helped me to be here and talk about pediatric pancreatitis, and we are looking forward to welcome new participants. And thank you for your kind attention.
Спасибо. Вопросы есть?